Respiratory diseases are categorized into three major pathophysiologic groups, which include obstructive, restrictive, and pulmonary vascular pathologies. Most patients will present with symptoms of cough and dyspnea as their primary clinical manifestation. Obstructive diseases are characterized by airflow limitation due to airway narrowing. Typical examples encountered in practice include asthma, COPD, bronchiectasis, restrictive bronchiolitis. Restrictive diseases are defined by reduced lung expansion, which leads to a decrease in overall lung volumes. These can be further classified into parenchymal, neuromuscular, or chest wall causes. Parenchymal restrictive causes include IPF and sarcoidosis, while neuromuscular causes include myasthenia gravis and ALS. Chest wall or pleural causes may involve conditions like kyphoscoliosis or pleural effusion. Pulmonary vascular diseases impair the flow of blood through the pulmonary circulation. Key examples include pulmonary embolism, pulmonary hypertension, and vasculitis. When assessing dyspnea, the quality of the sensation provides diagnostic clues. Chest tightness often suggests obstructive disease, whereas air hunger may point toward a cardiac etiology. The onset of dyspnea is equally critical for diagnosis. Acute onset suggests PE or pneumothorax, while chronic progressive dyspnea is more typical of COPD or IPF. Cough is classified by duration, with acute cough lasting less than 8 weeks and chronic cough exceeding 8 weeks. Sputum evaluation is necessary, as purulent secretions indicate infection and bloody sputum requires urgent evaluation for hemoptysis. Social and exposure histories provide vital context for respiratory health. Where must assess for smoking, occupational asbestos or silica exposure, and environmental triggers like wood smoke or bird exposure. Physical examination begins with vital signs, where tachypnea indicates respiratory distress. Inspection should focus on the use of accessory muscles and the patient's ability to speak in full sentences. Percussion findings are diagnostic, with dullness suggesting pleural effusion or consolidation. Hyperresonant notes typically suggest the presence of a pneumothorax. Palpation of tactile fremitus helps differentiate pathology. Fremitus is increased in lung consolidation, but decreased in pleural effusion or pneumothorax. Auscultation may reveal wheezes from airway obstruction or rhonchi from secretions in medium airways. These indicates an upper airway obstruction and must be treated as a medical emergency. Crackles or ralls can indicate pulmonary edema, pneumonia, or interstitial fibrosis. In IPF, these crackles often have a distinct Velcro-like quality. Special signs like egophony, where E sounds like A, suggest consolidation from pneumonia. Whispered pectoriloquy is also increased in areas of alveolar filling due to abnormal sound transmission. Signs of right heart failure or cor pulmonale include JVD, pedal edema, and hepatomegaly. These findings often complicate advanced chronic respiratory diseases. Digital clubbing is observed in lung cancer, IPF, and cystic fibrosis. Cyanosis occurs during severe hypoxemia when deoxygenated hemoglobin exceeds 5 grams per deciliter. The diagnostic evaluation begins with spirometry to assess for obstructive patterns. An FEV1 to FVC ratio of less than 70% is the definition of airway obstruction. Restrictive patterns are suspected when both FEV1 and FVC are reduced. Confirmation requires a TLC of less than 80% of the predicted volume. DLCO measures gas exchange efficiency across the alveolar capillary membrane. A decreased DLCO with restriction suggests parenchymal disease, while a low DLCO with normal spirometry points to vascular disease. Flow volume loops are useful for identifying large airway obstructions. Inspiratory plateaus suggest extrathoracic obstruction, while expiratory plateaus indicate intrathoracic obstruction. Arterial blood gas analysis measures oxygenation and ventilation via PaO2 and PaCO2. An increased A to A gradient is found in PE, pneumonia, and pulmonary edema. Chest imaging typically begins with a chest X-ray, though it may appear normal in asthma or PE contrast. Enhanced CT is the best test for evaluating pulmonary embolism and interstitial patterns. Bronchoscopy allows for direct visualization of the airways and collection of BAL or biopsies. This is essential for diagnosing tumors, infections, and certain interstitial diseases. In conclusion, a stepwise approach starting with history and spirometry is the gold standard for respiratory diagnosis. Clinicians must integrate physical signs and advanced imaging to confirm the underlying pathophysiology.